The cerebrum, cerebellum, and basal ganglia all help coordinate movements, so movement disorders can be traced back to these structures. Broadly, there are hypokinetic disorders, which cause slowness of movement, and hyperkinetic disorders, which cause excessive involuntary movement. We'll be talking about the hypokinetic disorders. Alright, when it comes to hypokinetic disorders, the term Parkinsonism refers to several conditions including Parkinson's disease itself, and other syndromes called Parkinson plus syndromes, which cause Parkinsonism plus other clinical features. These Parkinson plus syndromes include Lewy body dementia, multiple system atrophy, and progressive supranuclear palsy. Parkinsonism can also be caused by medications, including antipsychotics like haloperidol and antiemetics like metoclopramide. The four cardinal symptoms of Parkinsonism can be remembered with the mnemonic TRAP. T for tremor, which is classically described as a resting, pill-rolling tremor because it looks like somebody is rolling a pill between their thumb and index finger. R stands for rigidity, which is often described as a cogwheel-like rigidity. This means that when attempting to passively move a limb, there are a series of stops or stalls, kind of like a cog on a wheel. There's also lead pipe rigidity, which is when a limb is rigid throughout the entire passive movement, kind of like trying to move a lead pipe. Cogwheel and lead pipe rigidities are distinct from clasp knife rigidity that results from upper motor neuron lesions. In clasp knife rigidity, the limb is initially rigid like a lead pipe, but then it gives away, kind of like opening a clasp knife. A stands for akinesia, which is the absence of movement, and is a severe form of the more common finding of bradykinesia, which is slowness of movement. This can manifest as a narrow-based shuffling gait or a decreased facial expression, almost to the point where the individual's face looks like they're wearing a mask. P stands for postural instability, which causes a stooped posture, problems with balance, and an increased frequency of falls. Usually these symptoms are asymmetric, with the exception of medication-induced Parkinsonism, which usually causes symmetric symptoms. Now, Parkinson's disease is a slowly progressive genetic disorder that primarily affects individuals over 50 years old. The disease results from accumulation of the protein alpha-synuclein within neurons of the substantia nigra, which normally secrete dopamine. These intracellular inclusion bodies are called Lewy bodies. Now, within the basal ganglia, there's a balance between dopamine, which promotes movement, and acetylcholine, which inhibits movement. In Parkinson's disease, the loss of dopaminergic neurons results in less movement, as well as difficulties in speech and swallowing. In fact, a common complication in Parkinson's disease is aspiration pneumonia. Parkinson's disease also causes cognitive symptoms, like dementia in the later stages of the disease, affective symptoms like depression, sleep disturbances, and a loss of the ability to smell. Interestingly, seborrheic dermatitis, an oily skin rash that appears in the scalp, face, chest, and axilla, has also been associated with Parkinson's disease. The diagnosis of Parkinson's disease requires the presence of bradykinesia in addition to another one of the TRAP symptoms, and ruling out other potential causes. Treatment of Parkinson's disease is mainly aimed at relieving symptoms, either by increasing dopamine's effect or by decreasing acetylcholine's effect. Two groups of medications help increase dopamine's effect. The first group are medications that directly stimulate the dopamine receptor, like levodopa. Now, levodopa is given orally, and when it's absorbed, it's converted to dopamine by a decarboxylase enzyme. This conversion can happen peripherally, in the systemic circulation, or centrally in the central nervous system. But because our goal is to get most of the levodopa to the central nervous system, we combine it with carbidopa, a peripheral decarboxylase inhibitor. This decreases the peripheral conversion of levodopa to dopamine, and increases the central conversion of levodopa to dopamine. At the same time, combining levodopa with carbidopa alleviates some of levodopa's peripheral side effects, like nausea, hypertension, and cardiac arrhythmias. Two birds, one carbidopa. There are also dopamine agonists, which include the ergot alkaloids bromocriptine, cabergoline, and pergolide, as well as the non-ergot medications like pramipexole and ropinirole. The second group are medications that indirectly increase endogenous dopamine levels by preventing its degradation by certain enzymes. These include the monoamine oxidase B or MAOB inhibitors like selegiline, or catechol O-methyltransferase or COMT inhibitors like tolcapone and entacapone. Other medications aim to decrease acetylcholine's effect by blocking the acetylcholine receptor at the basal ganglia, and these include benztropine and trihexylphenadiol. Finally, there's amantadine, which has a mechanism of action in Parkinson's disease that's still being worked out. Now, levodopa-carbidopa is the best treatment available for Parkinson's disease, and is particularly effective at controlling motor symptoms like bradykinesia. However, its effectiveness can wear off after a number of years, and individuals can develop motor fluctuations, where the symptoms begin to reappear. In response, individuals often need an increase in the frequency of levodopa-carbidopa. And if that doesn't work, then a COMT or MAOB inhibitor can be added. Unfortunately, increasing dopamine levels can also lead to more side effects. These include cognitive symptoms like hallucinations and confusion, or motor symptoms like involuntary hyperkinetic movements called dyskinesias, or a feeling of restlessness and the need to move, called akathisia. An alternative to levodopa-carbidopa are the dopamine agonists. However, dopamine agonists aren't as effective as levodopa-carbidopa in the long run, and individuals are usually started on levodopa-carbidopa eventually. Dopamine agonists can also cause really striking side effects like hypersexuality, and an increased desire to gamble and shop. These side effects are thought to be due to the effects of dopamine on the brain, which alters the way a person controls their impulses. Anticholinergic medications are helpful when the motor symptoms are predominantly tremor or rigidity, but they're not as effective for bradykinesia or postural instability. Additionally, anticholinergics should be used with caution in elderly individuals and those with dementia, because they can cause side effects like delirium, dry mouth, exacerbation of glaucoma, urinary retention, and constipation. Finally, amantadine is an antiviral agent that can specifically help individuals with dyskinesias due to levodopa-carbidopa. Finally, if medications aren't effective at controlling symptoms, then a surgical treatment called deep brain stimulation can be done. In deep brain stimulation, an electrical lead is placed in the basal ganglia, and it's connected to an implantable pulse generator placed under the individual's clavicle. Deep brain stimulation is particularly helpful in individuals that have motor fluctuations, requiring frequent doses of levodopa-carbidopa, and it usually allows individuals to decrease other medications. Alright, now onto the Parkinson plus syndromes, which typically don't respond well to treatment with dopaminergic agents. First up is Lewy body dementia, which is distinct from Parkinson's disease in that the dementia symptoms usually come before the development of Parkinsonism, rather than the other way around. Lewy body dementia also causes very vivid visual hallucinations. Individuals with Lewy body dementia are also dopamine sensitive, meaning that they can have side effects even with low doses of dopaminergic medications. There's also multiple system atrophy, which causes Parkinsonism plus autonomic system failure, resulting in orthostatic hypotension, impotence, and urinary incontinence or retention. Another condition is progressive supranuclear palsy, which causes Parkinsonism plus a disturbance in downward eye gaze, and sometimes a disturbance in upward eye gaze as well. These individuals often also have cranial nerve palsies, dysphagia, and an increased frequency of falls, especially backwards. Finally, in individuals predisposed to strokes, multiple small vessel infarcts in the basal ganglia might cause a form of Parkinsonism called vascular Parkinsonism. These infarcts are often found on brain imaging, supporting the diagnosis. Finally, there's Wilson's disease, which usually causes liver disease, psychiatric changes like personality changes, depression, or psychosis, or even just an isolated movement disorder. Therefore, any individual less than 40 years of age with a movement disorder like tremor, chorea, or dystonia should be evaluated for Wilson's disease. This includes performing a slit lamp ophthalmoscopic examination to look for Kaiser-Fleischer rings, and measuring 24-hour urine copper and serum ceruloplasmin levels. In Wilson's disease, individuals have a high urine copper level and low serum ceruloplasmin level. Treatment includes copper chelating medications like penicillamine or trientine. Alright, as a quick recap. Hypokinetic disorders include Parkinson's disease and the Parkinson plus syndromes, all under the umbrella of Parkinsonism. The clinical features of Parkinsonism include arresting tremor, cogwheel or lead pipe rigidity, bradykinesia or akinesia, and postural instability. In addition to Parkinsonism, individuals with Parkinson's disease might also develop cognitive symptoms like dementia. The mainstay of treatment in Parkinson's disease is levodopa-carbidopa. If the individual develops motor fluctuations, then the dose is adjusted, and then a COMT inhibitor like entacapone or MAOB like selegiline is added. Individuals with tremor or rigidity can also be treated with anticholinergics, like benztropine. If medications fail to control symptoms of Parkinson's disease, consider deep brain stimulation. In terms of Parkinson plus syndromes, dementia followed by Parkinsonism and visual hallucinations might indicate Lewy body dementia. Autonomic dysfunction manifesting as orthostatic hypotension or impotence along with the Parkinsonism may indicate multiple system atrophy. Downward or upward gaze palsy and an increased frequency of falls along with Parkinsonism indicates progressive supranuclear palsy.